A 71-year-old man walks into his doctor's office feeling perfectly fine. He still drives himself. He still cuts his own grass. He still meets friends for cards. He is not sick. He is not scared. He is only there because his family said, "You should get your routine checkup." Visual cue. Older man walking into clinic, calm and healthy. The doctor listens to his heart, checks his blood pressure, looks over the chart, then says the sentence that sounds harmless. "Let's just run a few tests." 3 months later, that same man is recovering from a procedure he may never have needed. He is weaker. He is anxious. He has complications from treatment for something that may never have harmed him. And the life he had before that appointment, the lawn, the friends, the driving, the independence, is suddenly not the same. Visual cue. Domino effect from routine test to procedure to complication. I am Dr. George White, and I want to say something carefully. I am not against medical testing. I am not telling you to avoid doctors, and I am not telling you to ignore symptoms. Some tests save lives. Some screenings catch disease early. Some procedures are necessary. But after 65, the question changes. The question is no longer only, can this test find something? The better question is, if this test finds something, will treating it actually help me live longer, live better, and stay independent? Visual cue. Overlay text. Will this test change my life for the better? That question is where many seniors are left unprotected. There is a pattern in medicine called a cascade. A cascade begins when one test finds a small abnormal result. That result leads to another scan. The scan leads to a biopsy. The biopsy leads to a procedure. The procedure leads to a complication. And now, a person who felt fine before the first test is dealing with a medical problem created by the chain that followed. Visual cue, simple animation of chain links labeled test, scan, biopsy, treatment, complication. The cascade does not begin in the operating room. It begins when someone says yes to a test without asking what happens next. Now, look at this. When you are 50, routine screening often makes sense. You may catch a dangerous problem early and gain many healthy years. But after 65, and especially after 70 or 75, the math becomes more personal. Some slow-growing problems may never hurt you. Some treatments may take more from your life than the disease ever would. And recovery is not always as simple as it was when you were younger. Visual cue. Split screen of younger adult recovering quickly and older adult needing longer recovery. This is not about refusing care. This is about choosing care wisely. So today, I want to walk you through 5 medical checkups I would question carefully after 65. Not because they are always bad, but because they are often done too automatically. And before you say yes, you deserve to understand the risk, the benefit, and what the result would actually change. Stay with me, because the final one is a test many older adults accept without a second thought, even though the risk and benefit conversation changes a lot after 75. Visual cue. Doctor looking into camera, calm, serious tone. The first checkup to question is routine PSA prostate testing in older men who have no symptoms and average risk. Visual cue. Older man sitting in exam room, doctor reviewing blood test. Let me be clear. Prostate cancer is real. PSA testing can be useful. Men with symptoms, strong family history, previous abnormal results, or higher risk may need a very different conversation with their doctor. But for a man over 70 who has no urinary symptoms, no strong family history, and no previous prostate concern, routine PSA testing can open a door that is hard to close. Here is the problem. A PSA test may find a prostate cancer that is very slow growing, so slow that it may never cause pain, never spread, never affect urination, and never shorten that man's life. But once the word cancer appears on paper, fear enters the room. Visual cue. Lab report with elevated PSA highlighted. And fear can push people fast. A biopsy may be recommended. A specialist may be called. Then radiation, hormone therapy, or surgery may be discussed. Those treatments can be necessary for some men, but they can also carry real risks. Urinary leakage, sexual problems, fatigue, bowel issues, and a quality of life that may never return to what it was before treatment. Visual cue. Older man looking worried beside treatment options. This is why the PSA conversation after 70 should not be rushed. The question is not only, should we check the PSA? The better question is, doctor, if the PSA is high, what would we do next? Would we watch it? Would we biopsy? Would we treat? And would that treatment improve my life? Visual cue, overlay text. If it is abnormal, what happens next? That one question can change the whole appointment. If you have trouble starting urine, weak flow, blood in the urine, pain, frequent nighttime urination, or a strong family history, talk to your doctor. Do not ignore symptoms. But if you are older, healthy, and average risk, PSA testing should be a shared decision, not an automatic habit. Visual cue. Doctor and patient discussing calmly. Now this next part is important because it involves one of the biggest fears after 65, breaking a hip, falling, and losing independence. The second checkup to question is a bone density scan that automatically leads to long-term medication without a full fracture risk discussion. Visual cue. Older woman holding railing on stairs. Bone health matters. Osteoporosis is real. Hip fractures can be life-changing for seniors. A fall can mean surgery, rehab, a walker, and sometimes the loss of living alone. So I am not saying bone scans are useless. They can help, but a bone density scan is only one piece of the picture. It tells you how dense your bones are. It does not fully tell you how likely you are to fall. It does not measure your balance, your leg strength, your vision, your home safety, or whether your medications make you dizzy. Visual cue, graphic, bone density plus balance, plus vision, plus strength, plus home safety. Those things matter. Many seniors are told, your bone density is low, so start this medication. Sometimes that is the right choice, but sometimes the decision is made too quickly, without asking how high the person's real fracture risk is, or how long they should stay on treatment. Some bone medications can reduce fracture risk in the right patient, but long-term use can also carry rare serious problems, including unusual thigh bone fractures or jawbone issues, especially around dental procedures. These are not common, but they are serious enough that seniors deserve to hear about them before starting years of treatment. Visual cue. Simple medical animation of thigh bone with warning symbol. Now, look at the safer way to think about it. Ask your doctor, what is my actual fracture risk based on my full health picture, not just the scan? Ask, how long would I need this medication? Ask, when would we stop or take a break? Ask, what can I do to reduce falls? Visual cue, patient holding written questions, because fall prevention may be the most practical bone protection many seniors can start right away. Balance training, leg strengthening, removing loose rugs, better lighting, grab bars in the bathroom, proper shoes, vision checks, reviewing medicines that cause dizziness. These steps protect bones by preventing the fall in the first place. Visual cue, home safety checklist with grab bars, clear hallway, good shoes. Here is the rehook. So far you have seen the pattern. A test can be helpful, but the automatic treatment path after the test may be the real danger. Now we are going to the heart, where one just to be safe test can lead to a procedure inside the blood vessels. Visual cue, heart monitor line and treadmill. The third checkup to question is routine cardiac stress testing when you have no symptoms. This one sounds responsible. A doctor says, you are getting older, let's check your heart. You walk on a treadmill, or medicine is used to stress the heart, while the medical team watches how your heart responds. Visual cue, older man walking on treadmill stress test. What could be wrong with checking the heart? The issue is not the test itself. The issue is using it in people who feel well and have no symptoms. If you have chest pain, pressure, shortness of breath with activity, fainting, or unexplained dizziness during exercise, that is different. You should be evaluated. But if you have no symptoms, a routine stress test can sometimes create a false alarm. The test may suggest a problem that does not actually need a procedure, But once the result looks abnormal, the next step may be more invasive testing. Visual cue, stress test result turning into catheterization graphic that may lead to a cardiac catheterization, where a thin tube is placed through a blood vessel and guided toward the heart. This can be very useful in the right situation, but it also carries risks such as bleeding, blood vessel injury, abnormal heart rhythm, kidney strain from dye, and other complications. And if a partial blockage is found, a stent may be discussed. Stents can be life-saving during heart attacks and very helpful for certain symptoms. But for stable disease in someone without symptoms, the benefit is not always what people imagine. Sometimes the better path is medication, blood pressure control, cholesterol treatment, walking, better sleep, diabetes control, and smoking cessation. Visual cue, split screen, emergency heart care versus lifestyle and medication plan. So before a routine stress test, ask, what symptom are we investigating? Ask, if the test is abnormal, what is the next step? Ask, would that next step help me live longer or mainly lead to more procedures? Visual cue. Overlay text. What would we do with the result? This is not being difficult. This is being careful. For many older adults, the real heart protection is not another test. It is controlling the things that damage the arteries every day: high blood pressure, high cholesterol, high blood sugar, smoking, poor sleep, inactivity, and excess weight. Visual cue, blood pressure cuff, walking shoes, healthy plate, sleep clock. Now stay with me, because the next test sounds like a smart way to prevent stroke. And because stroke is so frightening, many seniors agree instantly. But in people with no symptoms, this test can create a dangerous chain. The fourth checkup to question is routine carotid artery ultrasound in adults with no stroke-like symptoms. Visual cue. Neck arteries highlighted on older adult silhouette. The carotid arteries are the large blood vessels in the neck that carry blood to the brain. A carotid ultrasound checks for narrowing or plaque. On the surface, it sounds logical. Find the blockage before it causes a stroke. But here is the problem. Many older adults have some plaque in these arteries. Some narrowing can be stable for years and never cause symptoms. But once the scan finds it, the conversation may move toward procedures. Visual cue. Ultrasound image leading to surgery icon. And carotid artery procedures are not small. In some people, especially older adults with other health problems, the procedure itself can increase the risk of stroke. A piece of plaque can break loose. Blood flow can be disturbed. The thing meant to prevent stroke can sometimes trigger one. That is why routine carotid artery screening is generally not recommended for adults who have no symptoms. Visual cue. Overlay text. No symptoms? Ask before screening. But listen carefully. If you have sudden weakness on one side, face drooping, slurred speech, sudden confusion, sudden vision loss in one eye, or a brief episode that looks like a mini stroke, that is completely different. That is not routine screening anymore. That is urgent evaluation. Visual cue, fast stroke signs, face, arms, speech, time. In that case, imaging may be necessary. Do not ignore stroke symptoms, even if they disappear. But if you feel fine and have never had stroke-like symptoms, your focus should usually be on the big stroke drivers: blood pressure, diabetes, cholesterol, smoking, atrial fibrillation, movement, and taking prescribed medicine correctly. Visual cue, stroke risk factor checklist. Now we come to the final test. This is the one many people feel nervous questioning because they have heard for years that it saves lives, and it can. But after 75, the conversation changes. The fifth checkup to question is routine colonoscopy after 75 in low-risk adults with no symptoms and clean previous screenings. Visual cue, older woman looking at appointment reminder. Colonoscopy can save lives. It can find polyps before they become cancer. It can detect colon cancer early. For many adults, it is an important screening tool. But after 75, especially if you have no symptoms, no family history, and previous clean colonoscopies, the decision should become more personal. The benefit may be smaller, and the risk may be higher. Visual cue, scale balancing, benefit and risk. The preparation alone can be hard on older adults. The bowel prep can cause dehydration, weakness, dizziness, and changes in body salts called electrolytes. That can strain the heart and kidneys. Sedation can also be harder on older adults. And although uncommon, colonoscopy can cause bleeding or a tear in the colon. Visual cue, prep drink, older adult looking weak, hospital monitor. In a younger person, a complication may be easier to recover from. In an older adult, one complication can mean hospitalization, rehab, loss of strength, and a long road back. So the question is not, is colonoscopy good or bad? The question is colonoscopy still the best screening choice for me now? Visual cue, doctor reviewing patient history and prior colonoscopy results. If you have blood in the stool, unexplained weight loss, new bowel changes, anemia, ongoing abdominal pain, or a strong family history, do not ignore it. You need evaluation. But if you are over 75, low risk, feeling well, and had clean previous screenings, ask your doctor about stool-based testing or whether continued screening is still useful for you. Visual cue, non-invasive stool test kit on counter. Now, let us bring this home. Every time a routine screening test is recommended after 65, especially when you feel well, I want you to ask 5 questions. Write them down. Put them in your phone. Bring them to your appointment. Visual cue, note card titled 5 Questions Before a Test. Ask, what is the false positive rate for someone my age? Ask, if this test finds something, what happens next? Ask, would treating that finding help me live longer or better? Ask, what are the risks of the follow-up test or treatment? Ask, is there a safer option like monitoring, medicine, lifestyle change, or a non-invasive test? These questions are not rude. They are not anti-doctor. They are not fear-based. They are the questions of a protected patient. Visual cue, older patient calmly asking doctor questions. A good doctor should welcome them, because the goal is not more testing. The goal is not less testing. The goal is the right test for the right person at the right time. Visual cue, overlay text, right test, right person, right time. And after 65, the right person part matters more than ever. Your age matters. Your symptoms matter. Your last test results matter. Your family history matters. Your ability to recover matters. Your goals matter. If your main goal is staying independent, walking without help, living at home, and enjoying time with your family, then every test should be judged against that goal. Visual cue, senior couple walking with grandchildren. Before your next appointment, write 1 question at the top of your notes. If this test is positive, what would we do differently? That question slows the cascade before it begins. Visual cue, dominoes stopping before falling. And please remember this clearly. Symptoms are different. If you have chest pain, blood in the stool, sudden weakness, sudden speech trouble, severe pain, fainting, unexplained weight loss, new confusion, or bleeding, get medical help. This video is not permission to delay care. It is permission to ask smarter questions when you feel well, and a routine test is suggested. Visual cue, emergency warning signs, then doctor consultation. The best medical care after 65 protects both life and independence. It does not chase every tiny finding just because a machine can see it. It does not treat a lab number without asking what the treatment will do to the person. It does not forget that a senior is not just trying to live longer. They are trying to live well. Visual cue, older man gardening again, peaceful home scene? So before you say yes to another routine test, ask the question that matters most. Will this help me keep the life I still love? If the answer is clear, move forward with confidence. If the answer is not clear, slow down and ask more. Share this with someone over 65 or with an adult child helping a parent make medical decisions. One better question before a test can prevent months of regret after a test. This video is for education only and does not replace personal medical advice. Your health history is your own. Always discuss screening decisions with your healthcare provider, especially if you have symptoms, previous abnormal results, or a strong family history.